So tonight on the call, there's myself that many of you are familiar with and I've corresponded with recently. I'm Susan Muirhead. I am the Support Services Manager at PKD Charity. Also on the call, I've got our CEO, Alison Taylor. Hello, Alison. Lovely to have you join us tonight. And our guest speaker, Anne Crompton. Anne is a kidney specialist nurse and part of the Kidney Choices team at Lancaster Teaching Hospitals. We have to do the obligatory medical disclaimer. This meeting is purely for information purposes only, and it's not a substitute for professional medical advice and medical examination. And you may be thinking, well, Anne's a nurse, but tonight she can't answer your personal questions. She doesn't have access to your full records. So this is a general broad brush approach. And always, if you are thinking and considering any changes to your treatment or your own care, etc., please consult with your doctor, your pharmacist, or another medical professional. And we cannot recommend or promote any treatments or any specific brands. So that's a disclaimer over and done with. We always have to carry that out. If you haven't joined us specifically for a webinar, you'll find it slightly different than when we've been hosting live meetings. In this one, you're in what we call view-only mode. So you can hear us talking and you'll be able to see the videos we're presenting. But you are able to interact with us. You'll see at the bottom of your screen, there's a little circle. It's a little speech and it's Q&A underneath it. If you were to open that little icon, you can type any questions or comments you may have, and Alison and myself will go through those while Anne's speaking, and we'll be able to ask them at the end of Anne's presentation. Many of your questions will be answered during the presentation, and we will stick to the topic of low kidney function and that clinic, that specialist clinic. We're unable to talk about other topics tonight. I know a couple of questions had come in. There was one in particular in Tolvaptan. I will follow up with that person tomorrow, and we will send out some links where you'll find information and previous presentations recorded, such as this, on the topics of Tolvaptan, transplantation, and living donation. That's some of the topics that there was questions had come through for tonight that maybe were just slightly off topic, but certainly lots of resources that you will find interesting. So we'll get those shared with you as well. And that is us. I would like now to hand over to Anne. Good evening, Anne.
Good evening, everybody. Susan asked me to talk about the Advanced Kidney Care Clinic. That's a relatively new name that some people are more familiar with the term low clearance. So we're trying to move away from that really. And as a national thing, national QI project that I've been involved with recently that's ongoing is all about trying to do away with jargon and, different terms for the same thing. So we don't really use the term low clearance now much, but most advanced kidney care clinics are now the new name for the old low clearance clinics. And they're for clinics for people who have low kidney function. And they've usually moved on from a general nephrology clinic into an advanced kidney care clinic when their kidney functions around 20% or a GFR of 20 mils a minute or less. It's an opportunity for people to see a kidney consultant, a specialist nurse like myself, to give them a bit more information about how to manage symptoms and possibly about future treatments such as transplant and dialysis. Or for people who are older and frailer, they might not actually be being planned for dialysis. It just depends on how, what your medical history is, your age, and obviously your preferences. So I thought I'd start tonight by just giving you some tips for keeping your kidney function as good as possible for as long as possible, because that's a question that I get asked all the time. And a lot of people have asked me over the years, I've been 17 years in this job, about is there any special foods that you can eat to make your kidney function better? And the truth is, no, there isn't. Otherwise, we'd be telling you to eat it. But what I will say is that be very careful about going on to general websites about kidney problems, because not everybody needs to have a special diet when they've got kidney disease. Some people can eat a completely normal diet and not have to bother about limiting things like minerals like potassium or phosphate. It's always going off your blood test results, because if you start limiting particularly things like potassium and you don't need to, you can actually do yourself more harm than good, because potassium levels need to be normal for your heart rhythm to be normal. And too lower potassium, if you're limiting it without needing to, can actually be as dangerous for your heart rhythm as too higher potassium, because your kidneys aren't filtering it. So always be really careful about, changing your diet. So the key goal of any kidney clinic is to make sure that good blood pressure control is maintained as far as possible. And I can't stress enough that if you have access to a blood pressure monitor at home, even if you only do it once a week, or once a couple of times a month, it's always good to just check in and make sure that it's adequately controlled. And we're trying to keep it no higher than 140 on the top level and about 75 to 80 on the bottom level, the bottom number, because good blood pressure control is going to give your kidneys the best chance of staying good for as long as possible. And I've just listed there some of the common blood pressure medications. There is a slight typo on the last one, but many of you will probably be taking some, not all, of drugs like ramipril, candesartan, irbesartan, amlodipine, and doxazosin. And then obviously just general tips for keeping healthy. Always consider having a flu vaccination, because if you have low kidney function less than 20%, and you get the flu, it can really be quite devastating for your kidney blood, your kidney function. It's a common cold without any complications such as pneumonia or leading to a severe chest infection can drop your kidney function by 5%. And if you end up on antibiotics, you can have a bigger drop than that. So always, and be sensible about friends and family. If they're full of a cold, say, well, will you please keep away from, don't visit my house, because if I get that, I'm going to be a lot sicker than you will be. Always make sure that you're taking your medications as advised by your GP, your consultant. But be a bit careful if you are taking medications for things like urinary tract infections, because there's a couple of antibiotics, trimethoprim and nitrofurantoin, which are never really recommended by kidney doctors, but they're used quite widely in general practice. So always be a bit cautious about antibiotics. Most are okay, so long as obviously you don't have any known allergies to them. But trimethoprim and nitrofurantoin are not usually recommended for people with low kidney function. Always get advice about treating infections quickly. If you have diarrhea and vomiting, never put up with that for longer than a day, because if you have diarrhea and vomiting, you can get dehydrated extremely quickly. And if you have a high fever, that can also lead to dehydration, and fragile kidneys do not like being dry. And if you're very, very dehydrated, it can again cause a big drop in your kidney function, which you want to avoid. So always seek advice quickly for infections, particularly diarrhea and vomiting. And if you do have diabetes, then keeping good control of your blood sugars also gives your kidneys a better chance of staying good for longer. So when we're talking about treatments, the main goal of an advanced kidney care clinic really is to monitor your kidney function and respond in a timely way to symptoms that you might notice when your kidney function gets worse. Because most people, when their kidney function's between about 15 to 20%, GFR 15 to 20 mils a minute, they don't really have many symptoms at all. So what we're trying to establish with people is we're trying to start transplant workup, because if you are fit enough to have a kidney transplant, then that will be ultimately your best treatment for when your kidney function gets low. And people are typically activated on the transplant list when their kidney function is less than 15%. So if you can start developing some healthy habits before, as you start the transplant workup, when your kidney function's around 20, such as giving up smoking or at least cutting down. I know giving up smoking when you're already stressed because your kidney function's getting worse is easier said than done, but there's lots of help available. And at least if you can cut down, that would be fabulous, because giving up smoking is not only beneficial for your general health and your lungs, it's crucial for your blood vessels. And blood vessel health is really important in kidney transplant, because obviously we're going to be grafting a new kidney onto some quite major blood vessels near the top of your leg. So we need those blood vessels to be as healthy as possible. Keep to a sensible alcohol intake, and as healthy a weight as possible. And if you do need to lose weight, high body mass index does affect people's chances of a transplant, and there are quite strict upper limits for body mass index, and if you're above those, you'll be asked to lose weight before you're considered for a transplant. The key to maintaining good blood pressure, again, is limit your salt, and I'm sure that everybody on this call has been told to do that before now. And if you can exercise, even if it's only, or getting out for a walk, even if you don't walk quickly, getting out for a walk, as often as you can, is also beneficial to blood pressure and keeps you, it can be help with mental well-being too. So I just thought I'd talk about some common symptoms. Tiredness and low energy levels, feeling cold, are often the thing that most people identify with. And the tiredness can come from increased toxins in the blood, but sometimes it can also be down to anemia. And anemia treatment is something that starts usually well before any planning for dialysis gets going in earnest. A lot of people can become very anemic, and obviously people with polycystic kidneys, if they have bleeding cysts and lose quite a lot of blood, then obviously that can lead to a sudden drop in their red blood cell count. And we try and avoid, where possible, to have a blood transfusion, because every time you have a blood transfusion, you make some antibodies, which ultimately can affect your chances of a transplant. It doesn't stop you having a transplant, but it can make you harder to transplant if you've had a lot of blood transfusions. So we try and not to do those. And we treat anemia using intravenous iron infusions, because a lot of people with low kidney function don't absorb iron from their diet, or particularly iron tablets, very well. And some people are actually highly intolerant of iron tablets. It can cause gripey guts, stomach pains, stomach cramps, bouts of diarrhea and constipation, generally very unpleasant symptoms. And you're still not absorbing the iron. So the best way of giving it can be through an intravenous infusion, which you might need 2 or 3 of in a calendar year. So not too onerous in terms of appointments. And the usual first time you have an iron infusion, it's a little cannula in the back of your hand that we administer the iron through in about 30 minutes, and then subsequent ones can be given over 15 to 20 minutes. You need iron to make red blood cells, because there's a hormone that comes from healthy kidneys that tells the bone marrow in the thigh to make red blood cells, and iron is needed for the bone marrow to make the red blood cells. And you can also start on some tablets called roxadustat, which are given 3 times a week, which make your body think that you're living at the top of Mount Everest, so that you make more red blood cells. And the alternative to those is a little injection once a month under the skin, which is a lab-made form of the hormone that healthy kidneys make that tells this bone marrow to make red blood cells. And once you've been on that treatment for about 6 to 8 weeks, we should see a difference in the red blood cell count. And hopefully people will have better energy and feel less cold. But tiredness is something that a lot of kidney patients do learn to live with, and pacing yourself and, trying to get enough sleep, and poor sleep is really common as well. It's all about being kind to yourself at the end of the day as well. Some people experience itching when their kidney function gets low. And typically I'm talking, when the kidney function's around 15% or less. Dry skin is really common in kidney problems and can make itching even worse because the skin's easily irritated when it's drier. So unperfumed moisturisers, anti-itch creams such as Urax, which is marketed really for chickenpox type things, but can be effective for some people. Tablets such as chlorpheniramine, commonly known as Piriton, or cetirizine, those antihistamine tablets, some people find those helpful, other people don't. And there is a drug called Atarax, which your GP can prescribe. The others are available over the counter. That sometimes is a bit more effective than just a simple over-the-counter antihistamine if your itching's really bad. But always mention it in clinics if it's really uncomfortable for you, because there are other drugs that we can go on to once we've tried all of the above, the moisturisers, the anti-itch and the Atarax. Poor appetite is something that most people start to identify with when their kidney function gets a bit lower. Having said that, some people don't have any problems eating at all. But if you are affected by poor appetite, and sometimes obviously when the polycystic kidneys are very big, it does affect how much food you can eat. We always say stick to smaller, like 5 snacky type meals rather than 3 main meals. Plain food, not too spicy and not too highly flavoured. Cold foods, because cooking smells can really put you off even before you even attempt to eat. And always get advice from a dietitian, which you should have access to in an advanced kidney care clinic. But just be really careful with things like Complan and, build-up drinks, because not all are kidney friendly. Sometimes they have a lot of potassium and phosphate in. And if you're being asked to limit those, the supplements that you might reach for from the supermarket shelf might have a lot of those minerals in without you realising. So just be a bit careful with the supplements. Most dietitians will be able to point you in the right direction. Nausea and vomiting, something that happens when the kidney function starts to get quite low, typically below 10%, but some people get quite sick sometimes. Cyclizine particularly is very good. Metoclopramide calms the guts down and slows the guts down a little bit. And regular sodium bicarbonate capsules, if your blood is a bit acidic, can stop that horrible bilious feeling that a lot of people have. But you'll only be prescribed that if your blood results show that your sodium bicarbonate level in the blood is less than 20 millimoles per litre. Some people do have problems passing enough urine, but that is not something that people with polycystic kidneys who still have their native kidneys, have problems with. Most people with polycystic kidney disease actually carry on passing urine very well. But if you do have problems passing enough urine, diuretic tablets like furosemide might need to be considered, because living with swollen legs and easily becoming breathless is never pleasant, and it's trying to strike a balance between a small dose of diuretics, maybe limiting your fluid intake, because we don't want the furosemide will drive the kidneys to work harder to make a bit more urine, and sometimes your blood test results can look a bit worse as a result of that. But if the symptoms of fluid retention, like the swollen legs, tight skin on your legs, that splits easily, and sometimes legs can leak fluid when they're really, really swollen. The skin becomes very shiny. Anything like that, we've got to start resorting to water tablets like furosemide to keep you in a comfortable condition. Next slide, please, Susan. Some people talk about poor concentration and sleep problems. Some people start making lists or note times of, set reminders on their phones to about tablets and appointments. But in the main, most people, although they might not have the concentration that they did have when their kidney function gets quite low, say less than 10%, that it's all about trying to find little daily hacks that'll just keep you on the straight and narrow. But psychological support, sometimes there's lots of renal units have psychologists available to them. And obviously some tablets, if your sleep problems are really bad, please discuss it with your consultant when you go to clinic, because there might be some tablets that he can recommend in the short term if you're really, really climbing the walls because you're so sleep deprived. And some people are sleeping the clock round and can't hardly wake up. So there's things at the end of both spectrums. Lots of people talk about muscle, back pain, particularly around the kidneys. And obviously people with polycystic kidneys, if you're struggling with burst cysts or infected cysts, then, that's massive acute pain. And this is not the type of pain I'm talking about now. This is just general aches and pains in the joints, round your back, muscle. You feel all right when you sat down, but as soon as you get up, you feel like you need to sit down again. So, rest as much as possible. Ice packs, heat pads, hot water bottles sometimes, but just be really careful about not having them on your skin for too long, particularly if you're diabetic and don't have as much nerve receptors in your skin as you might have if you're not diabetic. Painkillers such as paracetamol are perfectly safe to take with low kidney function, but please avoid things like ibuprofen, Voltarol and naproxen, because they are absolute poison for anybody with fragile kidneys. Leg cramps can be a problem for a lot of people. Some people are prescribed quinine sulfate tablets. Tonic water often contains quinine, so if your doctor's a bit reluctant to prescribe anything, try quinine. Quinine-based tonic water. Some people find that really effective, and those tiny little cans that all the most famous tonic waters come in now are also good if you're limiting fluid to 150 mils. And sometimes there's gentle yoga poses which can help with restless legs. Some people find that their kidney function gets worse. Their kidneys go a bit nocturnal and they pass most of their urine at night. So sometimes limiting fluid for a couple of hours before bedtime. And if you're taking diuretics like furosemide, don't take them at night. Take them at the very latest by 2 o'clock in the afternoon. And then you've got time for them to work, do their job before then you're settling down for the night and want to go to sleep. And the sodium bicarbonate capsules can also help neutralise acidity in the blood. And if that is, if the acidity is quite high and the bicarbonate level's very low, then that can make you feel a bit short of breath. And they can also help to regulate potassium levels and sodium bicarb. But remember, shortness of breath can also indicate fluid overload. And particularly if you're not passing as much urine as you used to do and you're uncomfortable lying flat in bed at night and your breathing isn't comfortable, please talk to your doctor about that, because you might have noticed swollen legs and, more fluid retention. So moving on to talking about what's the best treatment for people who've got kidney failure. Kidney failure, most people, by kidney failure, we're talking about when the kidneys can no longer do the job that they're designed to do adequately. And most people don't really need any kind of renal replacement therapy until their kidney functions. Certainly for dialysis, we wouldn't be starting anything like that until the GFR is between about 5 and 8%. And people can live with those levels of kidney function for a long time if they're still passing urine. And it's all about how you feel. And I'll go on to talk about sort of like when your body's telling you the right time to start dialysis later on in the presentation. But transplant is considered the best treatment for people who've got chronic kidney disease, stage 5, less than 15%. Hemodialysis is usually 4 hours, 3 times a week, can be done at home or a dialysis unit, and needs a fistula, which is making a blood vessel in your arm out of 2 existing ones that are joined together. So we join an artery and a vein together to make a bigger vein, which we can use for dialysis. Peritoneal dialysis is sometimes possible. It's a tube in the abdomen which uses a natural membrane in the abdomen to filter toxins, and the tube is called a Tenkoff catheter. You can do manual bag exchanges where you attach the bag to and drain some special fluid in. It soaks up the toxins and then you drain it out a few hours later. And you can also do that type of dialysis with an overnight machine, but typically you'd need to spend 8 to 10 hours on your machine. So your sleep time is your dialysis time, and that's usually the treatment of choice for children, young adults. Next slide, please. That's just a bit of an overview. So the transplant can be from a deceased or a live donor. Transplant workup often begins when the kidney functions about 20 mils a minute or less. And it can take 6 to 12 months to complete all the workup investigations. So it's something that we start to do sooner rather than later, because most people can be activated on the transplant list when their GFR is consistently below 15 mils a minute. And I just thought I'd say it, but you don't need to be on dialysis to receive a kidney transplant. We would prefer it that everybody gets what we call a preemptive transplant before they need dialysis. But that obviously doesn't work out for a lot of people. So hemodialysis, and there's a little picture on this slide here, is something that is what most people end up being on. Dialysis in a hospital, treatment time 4 hours, 3 times a week. And it's a big chunk of time out of your week. And remember, most people don't need to start this until their GFR is between about 5 and 8 mils a minute. And even then, they can still be functioning quite well. And if you're passing urine, your potassium levels are fine, your bicarbonate levels are okay, and you're eating well and maintaining your weight, you don't need to start dialysis. We need to join an artery and a vein together in the arm, and probably get referred for that when the kidney functions around 10 to 12 mils a minute, if this is what the choice that you would make when the kidney function gets really low, to give us time for that vein to develop, because it's not something that we can use straight away. It has to be given at least 4 to 6 weeks from the time the surgery is done to join the 2 blood vessels together, and it's usually done as a day case, but we need 4 to 6 weeks for that vein to develop. And blood circulates around the machine, and those pumps that you see, the middle one will be circulating the blood, pulling about a mugful of blood out of your body every minute, and removing toxins and excess fluid if you need it. Not everybody needs fluid removal, but everybody who's on dialysis needs toxin removal. So each session gives you enough kidney function to last a few days, but then you need to come back and have it regularly. So most people attend Monday, Wednesday, Fridays, or Tuesday, Thursday, Saturdays. And 2 needles are put into the fistula and removed afterwards. So there's nothing left in your arm afterwards. So 1 needle will take blood from you to the machine, spin it round the filter, clean the blood, get rid of fluid if you need it. And then a second needle higher up will put the clean blood back in. And that will, as the blood goes around the body again, it'll pick up more toxins. And a lot of people feel tired and a bit lethargic afterwards, and most people just sleep or take it easy for the rest of the day when they finish their dialysis. But not everybody, feels the need to do that. It just depends on how you react. This just gives you a little idea of what peritoneal dialysis looks like, and this is the overnight machine that people use. So they've got a tube in their abdomen. The machine puts special dialysis fluid in, and takes about 15 minutes to drain in. And it usually leaves that fluid in the abdomen for about an hour to soak up all the toxins and get rid of the excess fluid. And then it will pull it out, so it'll drain out the fluid. And usually the machine will change the fluid in your abdomen about 5 to 6 times a night, but you'll tend to need between 8 and 10 hours on the machine. So most of that will be your sleep time, hopefully. And that doing that can actually leave your days free to live your life. But it's sometimes not possible if you've got really large polycystic kidneys, because there's physically not enough space in your abdomen to put about 2 litres of fluid in. And if you can't get 2 litres in, then you're not going to have adequate dialysis. So it's not for everybody with PKD. So the time you'll need to start is usually the GFR is down to between 5 and 8 mils a minute. Tiredness and fatigue and inability to do everyday tasks, even having a shower, can feel like you're climbing a mountain. It can be all these things can become really difficult when the toxins in the blood are very high. And if you're really struggling with eating and losing weight, every time you come into clinic, maybe you're coming to clinic every 4 to 6 weeks, your weight's going down by 1 kilogram in that time, the consultant's not going to tolerate that for very long and will be advising you to start dialysis, because nausea, vomiting and poor appetite is all. We don't want you to get deconditioned. And sometimes fluid retention is also the factor that makes the difference and causes people to need to start dialysis before anything else. But often people with polycystic kidneys do retain the ability to carry on passing urine even though their kidney function is very low. So the takeaway messages from tonight is people can have a really decent quality of life even though their kidney function's low. And if you're still able to pass urine, there's no need to restrict daily fluid intake. And what I said about diet, don't restrict anything in your diet unless you're told to. And the only thing that the carte blanche, one-size-fits-all advice is try and reduce your salt intake. But, anything else, please proceed with caution and be advised by a dietitian or your doctor. Medications might change when you start dialysis. You might need less in the way of blood pressure control because you're getting regular fluid removal on dialysis. And the whole purpose of dialysis is to keep you in a fit state of health for a transplant, because we can't transplant you if you're full of fluid and not enough, not eating well, because you need to do a lot of healing after your surgery. I think we're coming to the end now. Just a bit about activation on the transplant list. I've said before, most people are activated when their GFR is consistently below 15 mils a minute. Average wait time for a deceased donor in the UK is between 3 and 5 years, depending on how rare your blood group is. O and A are the most common blood types in this country. You might wait a bit longer if you're blood type B, because that's not so common. And on average, a kidney transplant can last between 7 to 15 years, but it's really common in our hospital to see people whose kidneys have, transplants have lasted 20 years. And anti-rejection medication can be taken every day to keep your new kidney well. That's a real massive thing. Not always remembering to take your medication. And if you're ill or planning a foreign holiday when you're on the transplant list, you are usually suspended and reactivated once you return home or recover from illness or infection. Because you need to be within about 4 hours travel time of your transplant unit. So hospital dialysis, hemodialysis can also be done at home. It doesn't have to be done in a hospital. You can have a slightly smaller machine. Treatment times can be more flexible. So instead of fitting in with the hospital's regime of 4 hours 3 times a week, you can sometimes do shorter, more frequent treatments, maybe 3 hours 5 to 6 times a week. But you can if you haven't got room to do dialysis at home, and it does, most people have a designated spare room, but if you haven't got anything like that, shared care at your local unit is also an option, because you can learn to put your own fistula needles in if you want to, manage your own dialysis, set your machine up, but you might not have the space to do dialysis at home yourself. And training times vary from 2 to 5 months, but I have known some people pick it up in about 4 weeks. So we've talked about advanced kidney care clinics. You've got access to a specialist nurse and a dietitian. Sometimes units have social workers that can help with advising about employment or benefits, because some people find that they can't work, as perhaps they have to drop from full-time hours to part-time hours. There's grants available from some kidney charities to, like they might help with a new bed or something like that. It's really individual help, but that's available for some people. And clinical psychologists are sometimes available to help, you adjust to all the life changes that are inevitable. And even transplant can mean a lot of psychological support is needed for some people, even though, a transplant is generally viewed as a very positive thing. So use them. So that's the end of the presentation. I hope you found it useful.
Thank you, Anne, for a very, very informative whistle-stop tour, effectively.
The whistle-stop tour,
but no, it was very, very informative. I ticked off, just as you were chatting, most of the questions asked in advance seem to have been answered there, and I think we can see in the chat if anything's going to be coming through.
Yeah.
We were just finished off there in the topic of dialysis and the potential maybe of doing it at home. One person wanted to know roughly what type of setup. You mentioned really we're looking at a spare room. Yeah. Is it the box room, or could we get away with the cupboard area under the stair with a little bit extra?
You do need a bit of space. If you're doing peritoneal dialysis, the tube in the tummy, which is obviously not for everybody with polycystic kidney disease, it will be your own bedroom, because the machine for that is very much accommodated in a bedroom. You just need a plug and a space for a few bags of fluid. But the bags of fluid are delivered to your house on a monthly basis. We can do fortnightly deliveries if you have very little space. And a lot of people have a spare room to put their boxes in. If you imagine how much space a single bed takes up, the floor space that single bed takes up, your boxes will probably be piled 3 to 4 feet high for a monthly delivery for your fluid, because you'll go through 2 to 2.5 boxes a day if you're on the overnight machine. For home hemodialysis, the machine is generally bigger and a bit more complicated, looking a bit more like the machine that you see in the hospital units. But there's also one called the next stage, NX stage. If some of you might have Googled that already, and that's a totally different looking machine, which is very easy to set up, and much easier to learn. So the time that you spend learning the machine on like a home therapy unit will be shorter than on a conventional dialysis machine. That's often more popular for people who've got smaller properties. Most people do like to have their dialysis machine, for their hemodialysis machine, in a spare room, because they can close the door on it and it's not like it's making your own house into a clinic. And obviously it's not for everybody, because some people don't want their house resembling a clinic and they'd rather go to a dialysis unit. It might be extremely convenient, with very good transport links, and they just prefer to do ordinary dialysis at a unit, or maybe do shared care at their local unit and learn to do a bit themselves, but, rely on the staff and take advantage of the facilities there. So that's why there are choices, because one size does not fit everybody.
Well, it's a massive topic. And I see someone's also asked, what support would they need at home to do dialysis at home?
Some people who live alone still manage to do any type of dialysis. It just depends on your own outlook on life. Often, if you have got a significant other at home, daughter, son, spouse, partner, whatever, they want to be involved. They're wanting to support you at home, and it's sometimes easier to train with. A lot of people train with somebody else. But it's with the peritoneal dialysis, we can probably teach somebody to do that within a working week. They start training on the Monday, and by Friday they're usually okay to go home, with a bit more support than the seasoned regulars have. But they're usually ready to go home by the Friday, some people even by the Wednesday. And if you've got a machine for peritoneal dialysis and you've got somebody who can help you set that up, then brilliant. Some people who are old and frail might do peritoneal dialysis, and we also have an assisted peritoneal dialysis service for people who live alone, who are a bit less confident, and some units do offer that. But the home hemodialysis, it's generally, if you've got somebody who can help you, it's sometimes a little bit easier but we still have some people who live alone and do that quite successfully.
Anne, can I just ask you a couple more questions about dialysis that have come from people who've put their questions this evening?
Yes.
Somebody's asked, a really straightforward question, is dialysis painful?
Right, okay. A lot of people ask me that, and I should have put it in the thing. Once the needles are in your arm for hemodialysis, you shouldn't feel them. Obviously, there's a little bit of pain when they go in. We can sometimes some patients use Emla cream, and they apply that on their arm to their needle sites before they go to the hospital, or for an hour before they put their own needles in. But once the needles are in the correct position in the fistula, you're not sat there, and if they're pricking or uncomfortable, they're not right, and the nurses need to adjust them and make them comfortable, because you shouldn't feel any pain once the needles are in. Sometimes the needles do become dislodged and can end up with they come out of the blood vessel, and you can end up with a big egg on your arm and quite a big bruise. We call that a blown fistula. That is something that can happen regularly when you're working on a dialysis unit, but it's not something that would be happening all the time. And it would be that would be painful. And the peritoneal dialysis, sometimes people feel a little bit of pain when the fluid is draining out. We call it drain pain. Sometimes it's worse when people have just started. Some women talk about it feeling a little bit like period pain. And sometimes some people are badly affected by drain pain because they don't. So we sometimes adjust the treatment so that there's always a tiny bit of fluid, say 200 mils left in the abdomen, to reduce drain pain, because some people don't like having a completely empty abdomen when they're on peritoneal dialysis. But usually no pain at all.
Thank you, Anne. Quite a few people have also got questions about things to do with sort of the run-up to being considered for transplant. So yes, if we could look at a couple of those now. Somebody's asked, does a donor need to be the same blood type as me if I was being worked up for a transplant?
No, they don't. It makes it easier if they are, but some people are able to donate to somebody who, through the paired pool scheme, for example. So you might not do a direct donation. So you and your donor can go into what we call the paired pool scheme, where your donor would donate to somebody else and their donor would donate to you. And sometimes you get, perhaps about 7 or 8 pairs of, 7 or 8 recipients, 7 or 8 donors, all having surgery on the same day across the country, and the kidneys are going all over the place. And, we've had some very complicated ones, but it all works out in the end, and somebody gets the best possible match for them. Some people can directly donate, but they need to have what we call plasma exchange for immediately before the surgery for a few days, to almost like we do it's like desensitizing, and where we spin the blood around a filter to remove the plasma, and replace it with some artificial plasma to replace some of the things in the blood that might cause rejection. That's sometimes used. But the paired pool scheme is, really good scheme for people who might not be compatible with somebody that they'd love to give a kidney to, but it's their way they can donate to somebody else so that their loved one can get a kidney from somebody who's compatible.
Thanks, Al. I've got one more question about transplants, and then I'll hand over to Susan, who may be looking at some other questions. Yeah. So somebody's asked, if I live in a remote area, would I be expected to move close to the transplant centre when I'm on the transplant list?
It depends. Obviously, Manchester, I'm speaking from my experience of Manchester, because we don't have a transplant centre at Preston where I work. So our local unit is Manchester. Our patch covers right up to Barrow-in-Furness. So our patients who live in Barrow-in-Furness are actually going to be commuting to Manchester to get a kidney. And I have known people who, perhaps, for example, the M6 is notorious for being gridlocked around Preston, and Manchester, M61, around Manchester. There are sometimes exceptional circumstances where we can actually, I've known the helicopters that are used for the North West Ambulance be utilised for people to get them to a hospital. But usually we ask that people are no longer than about 4 hours travelling time from a unit. So obviously for somebody who's living in the North West, who's on the Manchester transplant list, if you went to Cornwall, the likelihood is you'd have to suspend yourself, because you couldn't get back from Cornwall within 4 hours. Sometimes there's a bit more leeway, because it depends on if a kidney comes in, it's from a deceased donor and it's not been on, it's not been on ice for very long, you've got a bit more wiggle room with the travel time. But if somebody's very remote, I mean, we've got, we do have some quite remote areas in the Lake District, Milnthorpe, access is sometimes difficult, but generally we overcome it. And I know that people who live in the north of Cumbria will be expected to commute to Newcastle upon time for their transplants. So again, some of their, and transplants, transport links in those remote areas aren't always the best. And obviously areas of Scotland like the Highlands, snow, all the weather conditions, but usually we can overcome it because, we can use helicopters if we need to.
Thanks, Anne.
Just before we move away from the topic of transplantation, a lovely question that I'm asked quite often. When you get a transplant, do they transplant 2 or just 1 kidney?
Just usually 1.
Yeah.
So you'll end up, and obviously people with polycystic kidneys, it's because the kidneys sometimes become so big, or they are, people are suffering with terrible infections and pain and bleeding cysts. In that situation, sometimes we actually have to do nephrectomies to remove the polycystic kidneys, 1 or sometimes 2, before people can be activated on the transplant list, because we're, to actually have a massive polycystic kidney infection whilst you were on, if you were on medication to damp down your immune system, which you would be if you had a kidney, we could be putting you at real risk of awful infection complications from that. So we have to make sure that, for some people, and we're only talking a few, a very small percentage of patients, but some people do have to have 1 or both polycystic kidneys removed before we can accept them for transplant, which obviously, if you have no kidneys at all, you will be dialysis dependent. One day, decent kidney function, the next, none at all. But it's very, very unusual to remove 2 kidneys at the same time. It's usually done 1 and then another one later. But most people end up with 3 kidneys because they've got their 2 kidneys they were born with, and the transplant kidney is usually put in the lower part of the pelvis, near to the groin area, right or left, it doesn't really matter. It's up to the surgeon really, and how the blood vessels are. But that's where a new kidney is placed.
And a quickie question about holiday dialysis. Now, can you explain just briefly about holiday dialysis, both in the UK and overseas?
Usually, holiday dialysis is easier to arrange abroad than it is in the UK, because most renal units for hemodialysis don't really they're operating at 100% capacity all the time. But there are units like our unit in Kendal, who's the gateway to the Lake District, so we have a holiday slot there for people who are visiting the Lake District. So it's a question of just putting a few feelers out and finding out about holidays, and your local unit will always be helpful in liaising with another unit wherever you want to go on holiday. There's a lot of places in Europe like France, Spain, places like the Canary Islands, that it's relatively easy to still get dialysis even though we're no longer in the EU. Portugal, the Algarve, and places like Crete, the typical holiday destinations. Usually it's relatively easy to get holiday dialysis. And if you're on peritoneal dialysis, the companies can deliver fluid to wherever you're staying for the duration of your holiday, so that you can do your peritoneal dialysis. And some companies will even deliver a machine as well as the fluid. But some companies will expect you to take your own machine, and if that involves going on a plane, the airlines are very accommodating. It travels in the aircraft with you. It's accommodated as hand luggage, even though it's far in excess of any hand luggage weights. No airline on the planet would stand the bad publicity of preventing somebody who was on dialysis being able to go on holiday. So sometimes we ask you to take your machine, and we can be helpful in liaising with airlines to accommodate that being in the hold with you. Because if that goes in the hold and ends up in Abu Dhabi and you're going to Mallorca, it's no good to you at all. So there's lots of advice and help to accommodate dialysis. And in the UK, it's really quite easy to do fluid deliveries to somewhere else.
Alison, I'm aware that we've just got about 5 minutes or so to go. There's lots of questions coming through relating to transplantation. Now, we have lots of resources available of previous sessions which cover transplantation, matching for transplant, living donation, etc. They all have specific recordings which will last maybe 40 minutes to 60 minutes. So they're very, very in-depth. So a lot of your answers you'll find, and I will certainly circulate links where you'll find all of those tomorrow. Is there something there that's really caught your eye, Alison, just as we're coming to the closing minutes?
Bear with me, I'm just having a look through. Yes, somebody's actually asked, and I'm quite interested in this as well, how is the fistula created?
Okay, so arteries take blood from the heart down to the hand, and veins in your arm bring blood back up from the hand back to the heart. And a surgeon will usually do an incision at the wrist, usually about no bigger than 5 centimetres, and he'll locate an artery near to your wrist and actually cut the artery and plug it into the side of a vein. And through that incision, that's a really simple procedure which usually takes about 40 minutes to an hour to do. And blood's diverted from that artery and goes, instead of reaching the hand, it goes straight back up the vein. And over about 4 to 6 weeks, that vein becomes a little bit larger because the pressure within it, the blood pressure within that vein is now a bit higher than it was before, because blood pressure in arteries is always higher than veins. Other arteries in the hand will still provide blood and circulation to the hand, because we've got more than one artery in our arms that supply our hands. But that allows, we're looking for about half a upwards of 0.5 centimetre, a bit 6 millimetres, 7 millimetres for that vein to stretch up before we actually start using it. And it's the best way of getting at your blood to provide a decent blood flow to do dialysis through, because we can't obviously use tiny blood vessels that you have your blood taken from. So it's a good thing to, if you've got low kidney function, think about, maybe if you're right-handed, think about keeping your left arm, your non-dominant arm, free from blood tests, because ultimately the veins in the crook of your elbow will be used to provide blood for a fistula. And whether that's at your wrist or across your elbow, it's always good to preserve your forearm veins as far as possible. So try and stick to having blood tests on your right hand if you're right-handed, or your left hand if you're left-handed, because when you're on dialysis, your fistula will hopefully be in your non-dominant arm, leaving you plenty of, plenty of opportunities to use your dominant arm to play on your laptop, drink a cup of tea while you're on dialysis.